Hey YouTube, it's Marita from the Nurse Lounge, and today this video is by subscriber request, and the request was simple. She wanted me to basically tell a story of something that kind of happened tragically within nursing when it comes to mother or baby, and just kind of tell how that went. So if you want to hear one of my favorite stories to tell regarding a medical emergency, stay tuned. All right, so we're gonna jump right in. So again, I'm gonna tell you a story about a time in which I had a medical emergency with one of my patients, and so here we go, story time. All right, so I remember it being a Friday, and on this particular day, we had students, we had LPN students, and so the LPN students are not allowed to really do a whole lot on our floor. They were mainly had to observe, and we had I think 2 students on the floor. And because I am a nurse educator, I was working as a nurse that day, so I wasn't educating that day, but I was working as a floor nurse that day, a staff nurse. And because I am an educator, the charge nurse just said, "Hey, can she be with you today since this is what you do anyway?" And nobody else, you know how that goes. Nobody wanted a student, so I'm like, "Sure, she can do my work for me." So while she's learning, so that's just kind of how I saw that. So with that being said, she was an LPN student. She was probably, I think maybe her second rotation, second semester or trimester or whatever they call it. And so anyway, I had her the whole day, and so she needed an admission to do. She needed to do a head-to-toe assessment so that she can be checked off on it, basically. And even though I was not her instructor, I was there as a staff nurse. It's like, sure, I'll show you how to do the head-to-toe assessment. So when your actual instructor comes around, you'll know exactly what to do. So I got a fresh patient. She was a vaginal delivery. She had, I want to say, one other baby before. And I want to say it was within the year that she had it. So the babies were pretty much 9-10 months apart, okay? And so I get report on the patient. I don't remember the details of the report, just it was pretty much the baby. She had a baby, about 10 months prior, which in today's age, it's not a, I won't say it's not a big deal in terms of health wise, but it's not a big deal like, oh my gosh, it was nothing shocking about that. So anyway, I got her. She went to room 16. Now, some of you nurses, I'm sure in other areas of nursing, ICU or med surge even, or whatever, you have certain rooms that are your problem rooms. And so when you have your problem rooms, then you automatically know that when things go down, it go down in that room. So that's what this room was for me. But I'm like, she's going to be fine. I don't really think nothing of it. I'm not really superstitious like that where things happen. But not to spoil it, but so I had the student go to room 16. It's more numbers than that, but just for the sake of this video, room 16, and go ahead and do her assessment. At least go get her vital signs for me while I was getting everything else set up. So she goes down there and she does, I don't know if she does vital signs or not. All I know is she comes back running to me talking about the patient is green. And I'm like, green? What do you mean green? So when I think of green, I think of somebody throwing up, just like that emoji type thing. I think of somebody throwing up. So I'm like, okay, we'll give her emesis base and I'll be down there in a minute to, kind of assess to see what's going on. But I said, meantime, can you get some vital signs? And the school that this student went to can only do manual vital signs. They're not allowed to use a Dynamap machine. So she's like, well, I really couldn't because she looks green. And I'm like, what is this student talking about? I'm like, obviously she's just, y'all see, is she throwing up? What's going on? She said, no, you need to come quick. You need to come quick. So I was like, okay. So I go down to the room 16. And when I get to her room, she's not green. She was as white as this background back here. It was just white, like pale white, just sheet paper white, the sheet white. And so I'm like, are you okay? And so she was not really talking or really responsive. So I go pull her sheet down. And when I tell you there was blood everywhere, her whole sheet, her whole gown was covered from the waist down in blood, just drenching blood. So I'm like, oh my gosh, she's hemorrhaging. And so the student runs out the room. I don't know what she went to go do. So anyway, I push the call light and I say, hey, I need help. This patient is, I believe, hemorrhaging. So I go ahead, and if you know anything about a patient hemorrhaging, you have to do a vigorous fundal massage. So as I'm massaging her fundus, I'm beginning to realize that her uterus is deviated to, I want to say it was her right. So I knew her bladder was full. But at the same time, she's bleeding profusely. So I don't have time to go get a catheter and straight. I definitely can't get her up, number one, because she's bleeding profusely. Number two, I don't have time to go get a catheter because, you know, she's bleeding profusely. So I push the call light and I simply say, hey, I need help quick. I think my patient is hemorrhaging. So the nurse comes down, and she's very pregnant herself. And so she's running down there. I said, bring the dynamite machine with you. Because mind you, the student could not use a dynamite machine, and I didn't think to bring it with me because I'm thinking she is green, so she's probably throwing up. So we get it down there, and the blood pressure said 40/26. But I'm like, 40/26? So the nurse was like, do you want me to call the rapid response? And I'm like, no, because she's talking to me. I mean, and you know how they how they teach us in nursing school, you assess the patient, not the machine. So I'm like, 40/26? And she talking to me. We were talking about, you know, different things or whatever. And I said, okay. So she had a guest in the room with her. So things were getting kind of hairy. So I was like, you know, why don't you go to the waiting room? And once we get this whole thing situated, we will call you back to be with her. But they were having a conversation. So I'm like, I know you can't be 40/26. So I said, go check her blood pressure on the other arm. So the student's standing right beside me because she can't do nothing. And so the nurse who's pregnant, she goes and checks her blood pressure, and it says 40/26 on the other arm. And I'm like, yeah, go ahead and call rapid response. So we push for rapid response to come, and we're waiting and we're waiting and we're waiting. Now, mind you, when rapid response comes, you're supposed to get somebody from, and I may be wrong in all this because we don't call rapid response often, but I know somebody from ICU comes, respiratory comes, the house supervisor comes, usually somebody from the ER doctor comes. And there may be some other people that I'm missing. But basically, there's a team of people who do rapid response. And we didn't call a code. Don't ask me why. Well, she wasn't she wasn't in respiratory or cardiac arrest. That's why we didn't call a code, because there wasn't a code to be called. It was rapid response who had to be called. So we called them, and they did not come. So here we are. Mind you, it's me, the pregnant nurse, and the student from this LPN program who cannot do anything. So I'm like, okay, well, look, I already know what's going on. I'm still vigorously massaging her. I'm vigorously massaging her fundus. That's what I'm trying to say. I'm vigorously massaging her fundus to try to get this uterus to clamp down so it can control the bleeding. Well, you know, 10 minutes that went by and rapid response still had not came. So I'm pushing the call light again and calling the nursing station to say, hey, because we had a secretary. I said, can you please call rapid response again? No one has shown up. And I said, also, could you go ahead and page doctor, whatever her doctor, her OB doctor was. Well, guess where he was? He was in the OR doing another C-section, so he couldn't come out. So then we paged for any OB to come. So even though the OB didn't belong to her, she didn't belong to that group. We paged for any OB in the house to come because of the fact that we had someone who was, like I said, she was 40/26. This lady was about to die. And so the lady was telling me, the patient, she was probably in her, if I had to guess, maybe in her early 20s. She said, I can see the light. And I'm like, oh, no, not today, not today. I said, you come on back on this side. I mean, honestly, this woman was dying. She was bleeding out, dying. She said, I can see the light. I can see the light. And she kept on telling me that. We had a whole conversation while she is bleeding out. So I said, no, not today. So you have a baby that you just had. And I said, you have to be here for her. You have another, I don't remember, her son or daughter that she had. You have to be here for them. So I said, nope, you turn back away from that light. You come on back to me. And I kept on talking to her, So by then I had other nurses who had came and ran. So I had one nurse who went ahead and found, she took over the vigorous fundal massage for me while I went and got the Foley, because I needed to empty her bladder because I knew that was the culprit. And a lot of times, sidebar, a lot of times if you empty their bladder and make sure it's empty, you can prevent all this other stuff from happening. Not always, but a lot of the times it could. When I noticed that was her issue to begin with, then, you know, I tried to do it, but I couldn't because, again, I was the only nurse, me, the student, and the pregnant one, who was very pregnant, mind you. So we call rapid response again, and we call for any physician. One physician, matter of fact, he's the chief of OB. He called the floor from his office. Now, mind you, our hospital has caller ID, so we know where you're at when you're calling, okay? And he was just like, well, I'm not in, I'm just checking to see what's going on. I heard something was going on. I wanted to see if everything okay. Well, clearly everything ain't okay because we wouldn't be calling for any OB in the house. But he's like, well, I'm not on property right now, which was a lie because we could see that he, where he was calling from, that he was calling from his office, which was attached to the hospital. So I'm like, okay, you know what, forget it. I don't have time for this. So rapid response finally shows up. And mind you, I'm still doing this vigorous fundal massage. I'm just rubbing and rubbing and rubbing and rubbing and rubbing. And she's kept on saying, please, don't mess up my stitches, because she had stitches down there. She said, please don't rip open my stitches. Don't rip open my stitches. So while rapid response was there, they typically don't know what to do in OB because this is so not in their territory. So they're kind of like, so what's going on with her? I'm like, she's bleeding out, so what you mean what's going on with her? So I'm like, okay, so now mind you, is my patient. So I'm like, I need Trendelenburg position. I need a Foley put in. I need an IV line put in. And I'm up here just telling them what to do because ain't nobody doing nothing. We all standing there watching her bleed out. And I'm like, we need something done now. And I said, I feel like she probably has clots. I'm getting excited because I'm living over again. So let me slow down. This is exactly how I am on the floor. I'm like, this, and this. So, anyway, let me slow down. So I feel like she had probably some clots in her uterus that needed to be manually cleaned out. Let's just say it that way. And as a OB nurse, in terms of being a postpartum nurse, that's not within my scope of practice. So again, we need that OB doctor to come and take care of it. So he comes running down. They find him. He comes out the OR with the other C-section patient. And he hears it's his patient. So he comes running down the hall. And he comes to room 16. And at this point in time, we have the house supervisors there. She's pretty much doing like we had to do pad counts and kind of weigh them to see how much blood she's losing. And so she did that. We needed, I think, 4 units of packed red blood cells. So she had to go and get it delivered, go down there and pick that up for us. But anyway, so everybody's in the room, mind you. Everybody's in the room. So we have ICU nurses, we have ER nurse and ER doc. They have seen everything. They've seen trauma. They've seen people come in with their head half hanging off. Maybe not literally, but you know what I'm saying. So some gruesome stuff that they've seen. Well, that OB doctor, again, like I said, I knew that she probably had some clots, retained placental fragments that needed to be kind of cleaned out. That man, and men typically have big hands. So that man took his hand, it was gloved. I'm not sure if it's sterile gloves, but it was gloved. And he rammed his hand up in there. And she's like, this is the patient, don't hurt my stitches or something. She said like that. So even with her low blood pressures, it didn't get below 40/26, but with her low blood pressure, she's still hollering about them stitches down there. So I'm like, okay, well, at least she on this side hollering about some stitches. She's not, headed to that light that she was talking about. When he rammed his hand up in her vagina to kind of clean them clots out, and he busted her stitches, when I tell you, all them nurses and that ER doc flew and hit the wall because they had not seen anything like that where, the doctor would just ram his hand up somebody's vagina and kind of clean that out. So when I tell you they like to fill out, and if any of y'all are ICU nurses or, med surg or ER nurses or ER, whatever you happen to be, just know it was comical in hindsight. It's not comical when it was happening, but when hindsight happened, I'm like, oh my gosh, all them doctors and nurses just like flew and hit, the wall because they were like, and they gasped and like, oh my gosh, they couldn't handle it. I'm like, who's the students here? Who's the nurses here? Who's the doctor here? So I'm like, well, what the hell did rapid response come for? Because they surely didn't do nothing. The house supervisor, she did. And, one of our own nurses actually started the IV for me because she was starting the IV. Mind you, I have to record all this because guess who has to document this? So I'm the one who kind of gave orders. This is what I need. I needed somebody to start my IV. I needed somebody to put the Foley in. We had her in Trendelenburg. We were still doing fundal massage. The doctor finally came and kind of rammed his hand up and cleaned those clots out. But then after that, and all the doctor, the nurses, ICU nurses, respiratory therapists done hit the wall because they was just in so disbelief about the doctor ramming his hand up in there. Then there's like, oh, looks like y'all have everything taken care of. And truth be told, we already did. Mind you, you didn't come the first time we called for rep response. When you finally did show up, you didn't do anything because we already knew exactly what to do. I just needed an extra set of hands because that's just how it was. Now, when it comes to when we call rep response on our floor, keep in mind that it's heard hospital-wide when we call rep response. So therefore, our L&D nurses also heard it, and our nursery nurses heard it. So our L&D nurses are the critical care of our area. So they actually came running as well, and they were already there before rep response actually came. So we were already doing some things before they came to try to make sure that she don't die. Because I'm telling you, that patient was about to die if we hadn't did anything. So after that had happened, then we went and she had to have a pad count. We had blood. We were actually squeezing blood in. We had her a line going. We had to get a 20 gauge. I remember being in her right hand, I want to say, somewhere through here. I remember that vividly. Right hand, 20 gauge. And it was to the point we were just squeezing fluids and squeezing blood at the same time. It wouldn't even on a pump. We just squeezing it because we knew she needed volume because she was bleeding out. With that being said, the doctor did rip them stitches down there, and that lady hollered. So if nothing don't bring you back, pain will. So she hollered, and so then, mind you, we have 2 ORs on our floor. So we have 2 ORs, and then hospitals have their main OR that they use. But on our floor, we had 2 ORs, and they were both being used for other C-sections. So this was also an emergency. So we had to sit there and justify why we had to use the main OR, because I guess that costs more money. I don't know why that is, but we had to use the main OR. So he went down and she went and consented verbally for him to stitch her back up again. Cause like I said, he rammed his hand up in there and just tore everything back up down there. And anybody who had a baby or just think about that whole process and somebody doing something down there like that, you would be cringing as well. So, it was an exciting day. Now, after that happened, she was off the floor for about 2 hours. So it allowed me time to get my documentation caught up. But I had to document all that. I had to do the pad counts. I had to see how much they weighed. I had to actually weigh the pads. We had to, what else did we have to do? I have to go put in all these orders that the doctor was kind of saying we needed these things, but we didn't actually have orders for because of why? It was an emergency. So the house supervisor kind of overrid a lot of things regarding the blood and just got it from the blood bank and just brought it up, and we just start squeezing to get her her volume back up. And so anyway, this was probably about 2-3 o'clock in the afternoon or so. So she was gone till about 5 or so in the afternoon. Shift change for us is at 6:45, and so the student had left by then. And so she, was like, oh, I learned, she told me I learned so much from that. I don't know how you all do this every day. It don't happen every day, number one. Number two, you just do what you have to do. You know what the signs are of something, and you just do what you have to do. And that's what I did. I knew when I saw that blood, I knew exactly what the issue was, and that she was hemorrhaging. And when they're hemorrhaging, you have to stop the bleeding. You can go into shock like that, and like I said, you could die. So, her blood pressures came up eventually to the 70s, over 40s. Throughout this whole process, she went down to the main OR. He went back into manually tried to clean her out again to make sure he got all the fragments out, or whatever the situation was out. And then while he was in there, he stitched her back up. Now, mind you, anytime you have a situation or incident like that, there are so many hands involved, so many people involved, that there's a lot of documentation that has to be done. And when you have to do all this documentation, you have to be mindful that everything that happens has to be documented to the best of your ability. Because if something happens where she was to die later on, or she wanted to present with a lawsuit, my documentation was going to be everything. So I had everything in there, from the pad counts to what she did to I didn't really put the student part in there that she was green, but what I observed when I walked into the room, that she was actually more white, pale white. And that she was, and I saw that blood was everywhere once I pulled the sheet down. Everything has to be in your documentation so that it will, if something were to happen and comes to go to court, that you will be covered. And this probably happened now about 5 or 6 years ago. Now, with that being said, she went to the OR, got stitched back up. She came back to me about 5 or so in the afternoon. And of course, we had to administer the blood. And I had to do vigorous fundal massage for, I think, every 4 hours. We did for 24 hours. And she had to get medications like Methergin that we gave her, I think, PO every 4 hours. And so she got that. We gave her a shot of Methergin. We gave her morphine for her pain. We just did all the kinds of things that we usually do to help with that situation. After that, you know, I was very leery about her getting up and walking because, again, she had lost so much blood. I was very leery about her really eating because I didn't know we were going to have to go back to the OR at some point in time. And then with all that trauma down there that the doctor did trying to get her stitched back up again and clean out her vaginal vault, I didn't know if she was going to be able to pee. So I had requested for them to put a catheter in. That's like, oh, no, that's not necessary. So they didn't. So on my shift, like I said, she came back at 5. So if she peed the next shift, the night shift. But I said all that to say, I remember that story very vividly because of the fact that, you know, that student had told me that she looked green to her. And I still don't know to this day where she got the color green from. But hopefully this has been insightful for you. We do have tragic, you know, stories or things that happen in OB, and when it's uneventful, we appreciate it because the events that do happen, they happen. People about to die, you know, and I don't need nobody dying on me. And so the biggest thing, you know, after it's all said and done, she got to be with her baby. She lived. I'm assuming she's fine. It's been 5-6 years. The one thing we did talk about was her getting on birth control so that she did not get pregnant anytime soon from that point in time. Now, mind you, at this point it's 5 or 6 years, so she may have had another baby by now. I'm sorry. I don't know. But anyway, I just wanted to share that with you because that was something that was requested by a subscriber. Thank you for that request. That was, you know, keep the ideas coming. So if y'all have anything that you all want to see regarding OB nursing or just nursing in general, or a video you want me to do, I still have one coming up on postpartum assessments. And I actually had a crazy dream last night about nursing instructors and clinical instructors and what makes a good, I don't know why I dreamed it, but when I woke up, I'm like, that's a perfect idea. So I'm going to do a video on what makes a good nursing instructor or clinical instructor. So that's an idea that I have. So keep the ideas coming. I really appreciate you for being supportive and giving me ideas. And until the next time, you all take care. Bye-bye.